Okay. All right. Well, here we go with a couple of hours of what I hope is good information for you. And if anybody wants to ask a question or talk about a case, we can certainly do that. I think we've got plenty of time and plenty of flexibility within that time to cover more material. I've got my main computer here, which has about 6,000 articles in it, so we could go through articles if we need to go through articles to substantiate what we're going to talk about. But just think about that, as we go through the material, if you've got a case you want to bring up or if you've got a question, we certainly have, I think, more than enough material for the next day and a half. I think your note packet ultimately has about 270 pages, so it's basically a book, and we're going to go through pretty much every page. There's a section in there on labs, which we may or may not review. Kind of depends. I just wanted to get kind of a feel for what you as the audience want to cover. But we could cover labs. I teach labs here on campus for the master's program. And so maybe at some point we'll just get a feel for what we need to cover there. But what we're going to start out with today, right now, is a new protocol or a new presentation that I started putting together earlier this year. As some of you know, I've been lecturing on autoimmune diseases and inflammation for about 12 years now. And earlier this year, very serendipitously, a friend of mine was looking at my slides and she recommended that I do some reformatting, which of course I totally resisted because who is she to tell me how to format my slides, right? Well, as it turns out, just reformatting my slides forced me to organize the material in a different way. And after I did that, the material occurred to me in a different way, and then I ultimately ended up changing the entire protocol based on what started out as a cosmetic change, which then became an organizational change, which then became kind of a delivery and clinical application change. So it's been a good year for my presentations in that sense. I think the material now is easier to understand, it's easier for me to deliver, and I think it's easier for you to grab onto it. And you'll see that just within about the next 20 minutes. What I used to do, and Joe knows this very well, is I used to just pour on the data, basically. I'd get up there and run through my slides, and I hope people got it, but at least I'd covered the material, I think I did a presentation in Portland, Oregon a couple years ago in 2006, and I went through 330 slides in 90 minutes, because I'm all about data, right? But I realize not everybody is, and we have to frame that data within a kind of a template or a conceptual paradigm that we can actually apply clinically, right? So you'll see that when we go through the new protocol, it's easy to remember, it's easy to apply, and I would actually be brave enough to say that you can apply this to almost anything that comes into your office and you'll get some benefit. Now, within the protocol, we can tweak and we can emphasize and we can de-emphasize certain components, but you'll see that this one protocol has a lot of applications, and I'm actually quite pleased with it. So let's go through this. So in your note packet, you should have some slides that look like this. And sometimes I change the title, or it's not really clear from my perspective or the literature's perspective how we're going to ultimately call this, whether we call it immune dysfunction or inflammation dysfunction or dysregulated inflammation. There are a couple of different phrases we could use. Probably inflammation dysfunction, believe it or not, is actually probably the most accurate. So I've titled this Dysregulated Inflammation and Immune Activation as the Cause of Inflammation, Allergy, and Autoimmunity. Some of you, I'm sure, probably all of you, and some of us more than once, have read, Robin's Pathologic Basis of Disease, right? That's what we read in medical school and chiropractic college, naturopathic school. So, that book presents a very static model of disease, right? People have rheumatoid arthritis, and this is what their joints look like. People have Parkinson's, and this is what their substantia nigra looks like. So when disease is presented in a static model like that, it almost creates a sense of helplessness, I think, among patients and doctors, right? Because people have a disease as if they are a certain height or, something else about them that they can't change. And one of the ways, of course, that we look at things in a functional medicine model is that diseases are dynamic states. They're not static states. Now, of course, over time, things can become static, right? If a patient has rheumatoid arthritis for 20 years and they have joint disfigurement, are we going to be able to reverse that? Very, very unlikely, if not impossible, right? But what if a patient has early rheumatoid arthritis, they've got some joint inflammation, like the woman's hands that you're looking at here, she's rheumatoid arthritis. We're going to go through her case right now, actually. And then the young man next to her, 35 years old, he's got severe rheumatoid arthritis and psoriatic arthritis and Hashimoto's thyroiditis. So those are, especially in the early stages, very reversible. But if you look at them from a medical paradigm, once those people have those diseases, they are never going to get cured within the medical model, right? In fact, I remember reading an article a couple years ago on laboratory diagnosis of autoimmune disease. And the author said, and this was published in the Canadian Medical Association Journal in 2004, I think, she said, once a patient has positive anti-nuclear antibodies, which is obviously one of the tests for lupus and other autoimmune conditions, she says, once the test is positive, there's never a point in repeating the test because it will always be positive, right? So that's how they see things. They see things as once you have the disease, you have it forever. Well, obviously, some of us, especially me, would disagree with that, right? Because I've seen patients have positive anti-nuclear antibodies, they follow this protocol or even a light version of this protocol, and their anti-nuclear antibodies go to 0. And then they say, I feel so good, I don't need to take these nutritional supplements anymore. They get off the protocol, we retest them, and their anti-nuclear antibodies are positive again. They go back on the protocol, negative. They come back, they get off the protocol, they go positive again. So patients' adherence to the protocol fluctuates directly with whether they're positive or negative with their anti-nuclear antibodies. So, and I've seen that from the time I was a student at Bastyr. Some of my first patients with autoimmune conditions, they were told by their doctors, their rheumatologists and such, that they'd have those conditions forever, and I treat them for 1 month and, you know, we'd already have negative anti-nuclear antibodies. So I know the protocol works. Does it work perfectly all the time? Does anything ever work perfectly all the time? The answer is no, but it's very safe, very effective. We'll talk about drug interactions because I also, for the past year, I've taught pharmacology at University of Western States, so we can talk all about drugs. And ultimately, you know, the goal here in my hands is to help convey this protocol to you so that you can apply it. But so my goal is to communicate, but your goal has to be to apply this, right? So let's keep both of those goals in mind and make sure that you leave here, you know, later today, tomorrow, perhaps even before lunch, and you've got the protocol kind of in hand. I think it's pretty easy, and you'll notice another thing, and I've done this on purpose. Each of the presentations that we're going to go through today has the protocol in it every time, so there's going to be some redundancy. But there's a reason for that, because the first time you look at this, you're going to say, maybe you'll say, wow. By the second and third time you've seen it, you'll say, yeah, I get it. And by the fourth time, it'll be just common sense to you. And then when you hit the streets on Monday with your patients, you'll just be using the protocol. Hopefully. I think hopefully that'll make sense, and hopefully that'll be the way this plays out. So let's look at this patient right now. This is a patient I'm still actively treating, and we'll go through her. I'm going to introduce her case right now, and then we're going to go through her case in more detail later because I have more slides and more updates. And then after that, I'll give you some verbal updates because I'm still actively working with this patient. So this is a 51-year-old white female who presents in March of 2012 with severe, aggressive, drug-resistant rheumatoid arthritis. She's already seen board-certified rheumatologists. She's already seen specialists. By the time she came to see me, she had already been to the naturopathic clinic at NCNM in Portland. She had done a 26-day water-only fast with the interest of trying to kind of cure herself. That tells you a lot, right? Patients don't do a 26-day water-only fast unless they're very serious. So those are the kind of patients I want, because I knew she was willing to bring her into the bargain. So she's already been treated naturopathically. She's already been treated medically. She's done some self-treatment. She's read a lot. She's been very actively engaged in her own treatment program, and she still has severe treatment-resistant rheumatoid arthritis. If you don't know already, what I'd like for you to be familiar with is what the basic medical protocol is for a treatment of a condition like this. So if she goes to see a board-certified rheumatologist, she's going to get run through this medical protocol. And it's always the same. It starts with non-steroidal anti-inflammatory drugs, Tylenol, aspirin, prednisone, methotrexate, sulfasalazine, Plaquenil, and then they go to biologics. And she's already done all of that. We can go through those drugs in more detail later if you want to be more familiar with them. And then they were recommending some experimental drugs for her, right? So that's where she is. Like, she's practically at the no hope point at this point by the time she came to see me. So, drugs that have failed, not surprisingly. Prednisone, she had a modest response to 60 milligrams, which is a pretty high dose, right? So she didn't get much out of that. Methotrexate, nothing. Biologics, no response. They actually tried her on 2 different biologic drugs, right? Biologic drugs are like the bomb in the medical world for these conditions, and she didn't get any response at all. Now she's recommended to start a new experimental drug. Generally speaking, I think one of the ways we can look at these drugs, and again, we'll go through them more later, but most medical drugs are system poisons, basically. And I'm not trying to sound conspiratorial when I say that, but if you look at the way the drugs work, most drugs function by blocking normal function rather than enhancing optimal function. And all you have to do is look at the names of the drugs, right? Calcium channel blockers, beta blockers, HMG-CoA reductase inhibitors, etc. Most drugs are enzyme poisons or they're receptor blockers, things like that. So they never make the body work better. They just block a normal function in exchange for some other function. So if you look at the drugs that she's been on, prednisone, methotrexate, biologics, they basically block the immune system from carrying out its function, but they never make the immune system work better. They never address the underlying problem. In some cases, they actually make the overall disease worse. If you look at prednisone, for example. Now, prednisone can have some life-saving qualities, so I'm not slamming every application of prednisone. But if you look at its use for chronic disease management, it actually causes mitochondrial dysfunction, which is something we're going to talk about later, which you'll come to appreciate actually causes more inflammation. So the drug that's used to treat inflammation actually promotes inflammation. And I don't think that's been appreciated sufficiently. Interestingly, I just read this last week or so because I updated a new book on fibromyalgia. One of the drugs used to treat, so fibromyalgia, as you'll come to appreciate, is a disease of mitochondrial dysfunction. Well, one of the drugs used to treat fibromyalgia, amitriptyline, actually causes mitochondrial dysfunction. So the drug that's used to treat the disease actually makes the disease worse. And we could say the same thing about methotrexate, but even more so about biologics. Biologics are immune suppressive drugs, right? They block tumor necrosis factor alpha, so they are what I call immunoparalytic drugs. They basically paralyze the immune system, but they certainly don't make things better. In fact, there was a brilliant article written, and this was written a long time ago, like 2006 or so. There was an article written